I think we have some technical issue with the slides. However, we're going to talk today about one of the controversies that we are having in our daily practice in our clinics about the vitamin D testing and vitamin D supplementation. That's a debatable topic that and the debate here stem actually from the difference between, and there is no consensus yet about the optimum level of the vitamin D, and different guidelines are talking about the different, the optimum level and the different supplementation, and whether the vitamin D supplementation is important beyond the bone health or not. We know that in the last decade we have a lot of studies that shows association between low vitamin D and different diseases, from malignancies to diabetes to other endocrinologic disorders. However, a lot of studies also fail to show that the vitamin D supplementation can help in management of these diseases. So I think we got the slides now ready, and we'll start. So vitamin D deficiency is a common global problem. As we said, it's affecting an estimated 1 billion people worldwide. 50% of the global population experiencing vitamin D insufficiency, and the rates are higher in the low-income countries, people with darker skin, and those living at high latitude or in northern climates. More than 70% or 75% of population have vitamin D level below 75, while around 15 to 20% of them have severe deficiency below the level of 30 nanomole per liter. So as we said, owing to the wide distribution of the vitamin D receptors in different tissues, this raised the question about its deficiency relation to broad spectrum of diseases. Low vitamin D, however, was found to be associated with pathogenesis or worsening of various diseases, autoimmune disorders, musculoskeletal malignancies, although randomized trials showing that treatment of vitamin D insufficiency or deficiency did not lead to improving these conditions so far. This is the metabolism of the vitamin D, and you can see here that it is starting from conversion of the provitamin D by the exposure to ultraviolet light, and then the hydroxylation in the liver at 25 position, then at 1 in the kidney, and then the wide distribution all over the different tissues with the receptors all under the control and feedback of parathyroid hormone and calcitriol. There is specific groups who are at risk, high risk of vitamin D deficiency, and actually these are the group that we consider or recommend testing the vitamin D among of them. The first group is the elderly above 70 years old, and the age-related decline in vitamin D level is possibly due to decrease in the skin thickness, and elderly people may less mobile, B also have reduced caloric intake and impaired kidney function. That all factors that lead to putting this group in as a higher risk group for vitamin D deficiency. People who have fractured past or present are also a second high risk group. Darker skinned people require up to 6 times more sunlight to synthesize the same amount of vitamin D as lighter skinned people, which means that they are also in higher need for vitamin D supplementation. This next group is the people who are rarely going outdoors, for example, those who are night shifters or have their skin covered for long periods due to cultural or occupational reasons. People who are diet deficient, like vegans or malabsorption. People who are obese, and people who are taking medicine that affect the vitamin D levels, and specifically anticonvulsant and rifampicin. So as we said, the recommended vitamin D levels are still controversial. However, I try to stick to one of the guidelines in my slides, so we don't go a lot for the debates and for the differences. So the Endocrine Society are used to these numbers as the optimal insufficiency deficiency, or vitamin D toxicity. So the optimal level is 50 to 100 nanomole per liter, where some level below 25 nanomole per liters are deficiency level, and those who are having levels more than 250 nanomole per liters are in risk of vitamin D intoxication. The best marker of vitamin D status so far is the 25 hydroxy vitamin D, and it has been used by numerous agencies in the establishment of vitamin D dietary requirement and for population surveillance of vitamin D deficiency or inadequacy. So I will go now through some of the recommendations or the guideline practiced by the Endocrine Society for the 2024. And this updates replaced the 2011 evaluation and treatment and prevention of vitamin D deficiency guidelines. And it also focuses on the use of vitamin D to lower the risk of diseases in individuals without established indication for vitamin D treatment or testing. The first recommendation was in children and adolescents from first year of age till 18 years of age. They suggested empiric vitamin D supplementation to prevent nutritional rickets. Empiric vitamin D may include daily intake for fortified food, vitamin formulation that contain vitamin D as well. In the clinical trials included in this review, with respect to respiratory tract infection in children, vitamin D doses ranged from 300 to 2,000 units per day. Estimated weight average was approximately 1,200 international units per day. The second recommendation was about the older population. So in general, adult population below 50 years old, they suggested against empiric vitamin D supplementation. However, they recommended related to empiric vitamin D supplementation that exceeds the daily recommended requirement established by the Institute of Medicine. Adults in this age group should follow the recommended daily allowance of 600 units per day. Still in the same group of adults below 50 years old, and they also suggested that the benefit have not been established in clinical trial in this population of testing. And the panel suggests against routine screening in this age group population. When we move to the older group of 50 to 74 years old, the recommendation relate to empiric vitamin D supplementation, and they suggested against routine supplementation as well. And in adults in this group should follow the recommended daily allowance dose, which is 600 units, as we said before. However, it is up to 800 units in elder patient above the 70 years old. They also suggested against the routine testing in this specific group, 50 to 74 years old. And in general population above 75 years old and older, they suggested empiric vitamin D supplementation because of the potential to lower the risk of mortality. So this is one of the first time to see we recommend against. So the empiric vitamin D may include daily intake for fortified food, vitamin formulation, and contain vitamin D. And for empiric supplementation, daily lower dose vitamin D is preferred over the non-daily higher doses. Why they recommend that? Because in the clinical trials included in the systemic review that reported on the mortality outcome, vitamin D doses ranged from 400 to 3,000 units per day. The estimated weight average was approximately 900. Participants in many trials were allowed to remain on their same supplement before. However, in general population above 75 years and older, we still suggest against routine testing, even if they still suggest for the routine supplementation. They also suggest empiric vitamin D supplementation during pregnancy. We have already evidence that the vitamin D lower the risk of preeclampsia and intrauterine mortality, preterm birth, small for gestational age, birth, and neonatal mortality. And therefore, in the clinical trial, they suggest 600 to 5,000 units per day. So again, during pregnancy, the suggestion again is testing. However, the suggestion or recommendation for routine supplementation is high. For adults with high risk prediabetes, in addition to lifestyle modification, the Endocrine Society suggests empiric vitamin D supplementation to reduce the risk of progression to diabetes. Even they also still do not recommend for the routine testing. In age 50 years and older who have indication for vitamin D supplementation or treatment, they also suggest daily lower dose vitamin rather than higher dose weekly or monthly doses. Still, they are very tough against the routine screening for vitamin D level. In adults with dark complexion, they suggest against routine screening. However, they are still high-risk population and they need to be considered for daily requirement vitamin D supplementation. In obese population, the recommendation of being against routine screening is still there. This recommendation relates to general healthy adults with obesity who don't otherwise have established indication for vitamin D testing like osteoporosis, osteopenia, pathologic fracture, or hypocalcemia. So the key concepts, and to summarize these guidelines of the Endocrine Society, there is no evidence to support blanket supplementation with vitamin D for total population. However, severe vitamin D deficiency is a serious health concern. There is only weak evidence that mild deficiency is clinically significant. Vitamin D testing is expensive and there is no consensus on the optimal vitamin D serum level. Monitoring vitamin D level is also considered unnecessary. The best way to increase vitamin D level is by general population is to short bouts of sunlight exposure of around 20% of the body surface area. Supplementation can be recommended for asymptomatic people who are at high risk of vitamin D without the need for testing. Vitamin D toxicity is rare and require excessive and prolonged supplementation. However, there is emerging data suggest possible adverse effect associated with sustained high dose or high levels. This is some of my references, and this is the end, and thank you so much.